The following is a presentation on evaluating sleep-promoting interventions for hospitalized patients. It's a search strategy on sleep quality and delirium outcomes. Hello everyone, my name is Brooke Chambers. I am a registered nurse who currently works in an intensive care unit. The following presentation is important to me due to my own clinical experiences of caring for patients in their most vulnerable times of their lives. I have personally seen situations where patients' basic needs, such as proper rest, are forgotten, and their recovery has been largely affected. The primary purpose of this study is to present how poor sleep quality can affect patients' clinical outcomes as well as their incidence of delirium, and how sleep-promoting interventions can improve overall health outcomes and decrease the risk of morbidity and mortality. Sleep deprivation in hospitalized patients significantly impairs recovery, with patients averaging only about an average of 5 hours of fragmented sleep per night. This disruption leads to physiological, psychological, and systemic effects. Physically, patients may experience elevated blood pressure, increased cortisol, and decreased immunity, contributing to higher rates of infection, longer hospital stays, and increased mortality risk. Psychologically, sleep deprivation is associated with anxiety, depression, PTSD, and most notably, delirium, which causes fluctuating alertness and is linked to increased length of stay, mortality, and healthcare costs. Beyond the patient, sleep disturbances impact both families and healthcare systems. Family members often experience increased stress and impaired decision-making due to disrupted sleep. At a systems level, delirium alone can increase hospitalization costs by $1,532 to $20,000 per patient, contributing to overall financial strain and resource burden. To address this clinical practice problem, I developed a PCOAT question to guide my evidence-based practice research. The PCOAT question reads as follows. In adult patients hospitalized in the inpatient setting, how does implementing sleep-promoting interventions compared to standard hospital care without formal rest protocols affect sleep quality and incidence of delirium during the hospital stay? My research included patient populations in the inpatient care setting that required continued monitoring, procedures, and interventions that typically cause sleep disruptions while hospitalized. Through my research, I found multiple effective sleep interventions, including circadian rhythm, aligned patient care, environmental modifications, and sleep bundles. These interventions were compared to the current standards of patient care models, and then results were measured through sleep quality tools such as Richards Campbell Sleep Quality Index and Pittsburgh Sleep Quality Index. To further explore this clinical problem, I conducted a literature research to support my PCOAT question. I used databases including CINAHL, PubMed, and the University of St. Augustine for Health Sciences Library. I focused on peer-reviewed articles published within the last 5 years that specifically included adult hospitalized patients and examined sleep-promoting interventions, sleep quality, and delirium prevention. Articles were excluded if they were older than 5 years, non-scholarly, focused on pediatric populations, or conducted outside of the hospital setting. Initially, approximately 60 articles were identified, but after applying inclusion-exclusion criteria and removing studies with bias, small sample sizes, or limited outcome data, a total of 10 high-quality articles were selected for the final project. Next, I will discuss the synthesis of the literature and the major themes identified across the evidence. There were 4 primary themes identified throughout the literature. The first theme was that environmental disruptions decrease sleep quality. These disruptions were consistent across studies and included staff interruptions, noise, light, and ongoing clinical interventions. The second theme highlighted that sleep deprivation leads to an increased incidence of delirium and other adverse outcomes. These adverse outcomes included immune dysfunction, metabolic disturbances, increased mortality, neurological impairment, and decreased overall patient safety. The final 2 themes focused on effective interventions that improve sleep quality and patient recovery. Both non-pharmacological multi-component interventions were consistently shown to be effective. Environmental modifications included strategies such as eye masks, earplugs, quiet time, and minimizing nighttime interruptions. Similarly, multi-component interventions were also effective and included approaches such as delaying vital signs, reducing noise, and implementing sleep-focused care practice. Through my research, I found that there is a significant need for changes in current standardized practice. The clinical setting that requires the most change in standardized sleep protocols was focused in the acute hospital setting. Units that were at high risk for both sleep disruption and delirium included the intensive care unit, med-surg, and step-down units. Standardized practice for this patient population lacked proper sleep protocols, resulting in frequent awakening due to a lack of clustered care. The general environment included high levels of noise, light, and frequent interruptions in procedures. Based on the evidence, current hospital care practices do not adequately support proper sleep hygiene, which highlights the need for a practice change to improve patient sleep quality. Across the literature, sleep promoting interventions consistently resulted in improved sleep quality, decreased incidence of delirium, and overall better patient outcomes. The recommended practice change includes implementing non pharmacological interventions such as environmental modifications and circadian rhythm aligned care. Clinicians should focus on reducing noise, limiting light exposure, and minimizing unnecessary nighttime interruptions. Additional interventions include providing patients with sleep aids such as masks and earplugs and educating staff on sleep hygiene and the use of sleep bundles to promote rest. To evaluate the effectiveness of the new sleep promoting interventions, patient centered measurement tools will be used to assess both sleep quality and the incidence of delirium. Prior to implementation, baseline assessments will be performed to evaluate patients' current sleep quality. Following the initiation of the interventions, assessments will be conducted daily and on a per-shift basis, and patients will be monitored throughout their hospital stay. This data will then be collected and analyzed to determine whether the interventions lead to improvements in sleep quality and reductions in delirium rates. The overall goal will be to increase sleep quality and decrease delirium rates. Through these assessment tools, quantitative data will be collected to compare baseline versus post-intervention data. This data will be further analyzed to identify patient outcome trends following the new sleep promotion changes. When it is determined that the proposed change will positively impact patient outcomes and clinical staff, a plan for dissemination will begin. It is important for staff to be well informed as much as it is leadership. When staff are properly educated through both classes and poster boards, they will be more prone to accepting the new sleep intervention changes. To maintain appropriate monitoring of patient outcomes and the effects of the proposed changes, the new protocols will be initiated one unit at a time, beginning with areas that are most susceptible to poor sleep quality and delirium in their patients, such as in the intensive care unit. In conclusion, the initiation of sleep promotion interventions will positively impact acute care hospitalized patients. These interventions will include circadian rhythm aligned care, environmental modifications, and sleep hygiene education. When this practice change is initiated, patients' risk of mortality, delayed healing, and decreased immunity will improve significantly. Thank you for joining me for this presentation, and I hope you take away new knowledge that can be applied to your own clinical area of practice. And these are my references.